So what we're going to try to think about in each of these cases is this an essential or symptomatic headache? What that means is essential would be like a benign headache syndrome. Not to say the pain isn't severe, but migraine, cluster, tension type headache, something like that would be an example of an essential headache. A symptomatic headache, these are the ones you don't want to miss, where the headache is a symptom of some underlying condition, like the patient has a brain tumor or an aneurysm or sinusitis or a dental process, something like that. Of course, always want to make a specific diagnosis. As we'll see, the treatment for these is dramatically different in each case. Okay, so we have to make the right diagnosis first of all. We'll always ask, should we image? Because not every type of headache needs to have a brain scan, and then we'll discuss treatment. Okay, so here's our first case. So think about this, and as we're reading through this, think about what you would do for this real patient. 32-year-old woman complains of intermittent headaches. These began when she was 15 and typically come on 2 days before her period. She first gets a sensation of a black spot in her vision or blurred vision, followed by a left frontal throbbing sensation. She has associated nausea and is incapacitated by the headache. Okay, what do these sound like to you? Sound like migraine? Okay, tell me the things in these few sentences here that jump out at you as migraine. Okay, the visual disturbance, which usually comes on before the headache, right? What else? Nausea would be a lot more common with a migraine than a tension type headache. What else? Okay, yeah, age. This is younger women are much more likely to get headaches. So that would be typical. Someone mentioned associated with her period, which of course migraines are often hormonal. Did you say something? Yeah, migraines tend to be on one side. The pain tends to be throbbing in nature. So every word here is basically saying migraine, migraine, migraine. And also migraines tend to be incapacitating. So someone can have a real bad tension type headache and go to work and function. But if you've got a migraine, you're pretty well wiped out. Can't do anything during a migraine. Okay, so she has migraines. Just some pictures here, the various types of visual phenomena that patients can have with this, which are varied. Some patients see like a donut or just have a kaleidoscope effect or a black spot, as she did. I don't show a picture here, but some patients get this, they're called fortification spectra, these jagged, bright edges that can be bright and flashing, all kinds of visual symptoms, but that's generally during the painless period of time, and then the headache comes on sometime later. Okay, but this is what happened with this patient. This is where the dilemma comes in. For the last 6 months, her headache frequency has increased from 2 per month to 5 per week. She also has a dull headache present all the time in the left frontal area. Okay, this is what she takes. Imitrex, 100 milligram tabs, 18 a month. Okay, why 18? That's the maximum number allowed by her insurance. Also takes about 6 Excedrin migraine per day. Was recently placed on Vicodin. Takes 2 pills every 4 to 6 hours. And by the way, she drinks about 4 to 5 cups of coffee per day, has several Diet Cokes throughout the day, and her mother recently passed away. Okay, neurologic examination was normal. Okay, so just kind of imagine this patient now, severe headaches. She comes in, this is what she's taking. Okay, so let's ask the first question here. Do you think this patient needs to be imaged? If you were seeing her, would you get a scan? Well, there really isn't a right or wrong answer here. Probably not. She's had these headaches for a long time. She's got a normal neurologic examination. Wouldn't be wrong to image, but would you likely find something? No. So probably not. And if you were now going to give her a diagnosis, we know she has migraines, but what else would you add to your diagnosis number 2, maybe number 3? Rebound, okay, too much caffeine, rebound, that kind of relates, to each other. So she has rebound headaches. And what do you call someone that has a headache basically 24/7, all the time, never goes away? Chronic daily headache. That's probably the most common type of headache that I see, more than migraine. all right? And it's underdiagnosed. And the reason it's important that we remember this is there's very specific things we do for chronic daily headache. It often overlaps with migraine headaches. So she has migraines, she has associated chronic daily headaches, and she has rebound headaches. Now you mentioned caffeine, but is there anything else she's taking that might contribute to rebound headaches? Excedrin. What's in Excedrin? More caffeine, right? What else? Vicodin. Could Vicodin cause a rebound headache? Yeah. Anything else? Here's what she's taking. So you mentioned the Vicodin here, the caffeine in the Diet Coke, coffee, Excedrin. What about Imitrex? Do you think that would play into rebound headaches very much? Well, what is surprising is this was maybe a couple years ago, they did a study on rebound headaches and found that medications in the triptan family, remember sumatriptan, naratriptan, all of these triptans like Imitrex, may be even more potent for causing rebound headaches than caffeine narcotics. So all three of these abortive medications that she's on dramatically play into these rebound headaches. And Imitrex may be the worst, maybe in the family of some of the worst medications. So anyway, I guess the question now is, now that we've identified this is where she's at, what would you do for her? Okay, so preventive medication, Topamax. Do you think that would take care of the problem?
Not completely. She has to stop taking what she's taking.
Okay, she needs to stop taking what she's taking. Do you think that goes over real well? Why don't you stop taking all that stuff you're taking and see you in 3 months. But I think you're right.
Could do like a TCA or something too on top of it with her mom just dying and everything.
Okay, yeah, good thought. That may not be incidental that her headaches got worse when her mom passed away, a tricyclic antidepressant. Well, which of those would you think would be the most important? We mentioned a couple of preventive medications, coming off of what she's on.
Can we terminate the headache now and then like send home with something like that?
Well, you know, ideally that's what we'd like to do, terminate the headache. But you could, I mean, let's say we give her Dilaudid or morphine. Would that take care of the headache? Yeah, but for about how long?
Yeah.
So there is no easy road in this case. And actually, I like your thought about the preventive medications, but in studies it looks like when we start Topamax or a tricyclic antidepressant, when someone is overusing lots of medications like this, those medications are not very effective. So it's a good thing to do, but really the only meaningful intervention is detox at this point. This patient, you could start all kinds of preventive medications, but unless she detoxes, this is not going to turn around. And these are some of the longest conversations, I would say, that I have with patients. And this is such a frequent problem because you will never see the patient again unless you can effectively convince the patient that this is the road that they need to go down. And the reason is, well, you will probably tell the patient, hey, you know what? These medications are really part of the problem. This is like throwing gas on the fire, using all these medications, these abortive medications. And the patient will say, oh, I tried to quit, but my headache got worse, right? And so then you're going to have to explain, yes, and when you detox, things will get worse before they get better. But the only way to get better is to detox. And how long would you think the window would be? How long does someone need to be off of all of these medications before they would turn the corner? And just guess, days, weeks, 2 weeks, months? Looks like it's between 3 to 4 weeks. So I always feel bad when someone, like someone I saw recently that drank about 3 pots of coffee per day. I told them stop caffeine. We went through this. I explained the 3 or 4 weeks, and they were off for about 10 days. And no, it didn't help. Came back to tell your doctor it didn't help. Well, you didn't do it long enough. So they really need to be at least in this 3 to 4 week period of time. Now, in this patient who is so greatly overusing medications in 3 categories, inpatient detox really seemed like the only option. So she went into an inpatient facility, actually to the Behavioral Medical Center right here in this area. And what they do is they load the patients up with Valium, and they just abruptly stop everything. And as she described it, it was terrible. I mean, for the first 5 days, 7 days, her headaches were awful. But she made it through it. So she went through detox, and her headaches decreased to 1 per week. And so things were better. Her chronic headache was better, but still present. Okay, so we still now we have something meaningful we can do, because her headaches are better, but she's now detoxed. So treatment is kind of what you're talking about here. And basically, the preventive treatment for migraine headache falls into one of 3 major families: tricyclic antidepressants, anticonvulsants, and beta blockers. And so there's different advantages and disadvantages to each of these. In the tricyclic antidepressant category, it's always a little frustrating. Your textbooks and review books always talk about Elavil or amitriptyline. But in the real world, every place I've ever trained or worked, neurologists use Pamelor or nortriptyline. And the reason is the side effects are much less with Pamelor. Less drowsiness, less dry mouth, less sedation. So tend to use Pamelor and slowly work up to 50 milligrams. That's a good dose. The reason I think in this case a tricyclic antidepressant would be the drug of choice is I think there was some depression. And also tricyclic antidepressants work well for the chronic daily headache. So when someone has an everyday, all the time underlying headache, tricyclic antidepressants generally work better than anticonvulsants or beta blockers. Anticonvulsants and beta blockers work great for migraine prevention, not as well for chronic daily headaches as a tricyclic antidepressant. Okay, so actually what I did for her is I started her on Pamelor when she went into detox, because it takes about 3 weeks for this to really kick in. And so by the time then she's detoxed, one is working as the others are wearing out of her system. But anticonvulsants are great. Topamax, for example, is a very effective medication for migraine prevention, maybe the best one we have for migraine prevention. Depakote also works well, but when you just compare the side effect profile, well, what do you know about Topamax? What might be some side effects with Topamax? Not so much sleepiness, but especially word-finding difficulty is a unique thing for Topamax. As you know, some patients refer to this as Dopamax, as they come back and they can't come up with the right word in conversation. They want to say that chair over there, and they just can't think of the word. Kidney stones would also be a side effect, not real common, but it is something specific for Topamax. But the most common reason for stopping Topamax is numbness and tingling. So numbness and tingling around the mouth and the hands. It's a carbonic anhydrase inhibitor, so that's a common side effect. If you warn patients about it, then they won't panic and stop it. Okay, and it often does get better after they've been on it for a while. And the other is weight loss. So very common to lose 8-10 pounds on Topamax. And again, just if you're comparing and you're talking with a patient, well, I could put you on Depakote, you might gain a lot of weight. I could put you on Topamax, you might lose 8-10 pounds. Again, for most patients, that's an easy, that's a no-brainer kind of a decision. Okay, and beta blockers, also very effective for migraine prevention. Usually we use propranolol, and if you can get a patient up to maybe 60 or 80 milligrams long-acting, once-a-day propranolol works great. This will be something they might ask you on your board test. What would be some contraindications for using beta blockers in a migraine patient? Yeah, if someone has bradycardia, certainly, and that's something we monitor when we put someone on propranolol, just have them check their pulse. What else? Asthma, that would probably be the number one thing to remember. And also depression, beta blockers can worsen depression. So in this patient, probably wouldn't be a great choice. given the fact she may have some underlying depression. So anyway, she got on Pamelor, and her chronic daily headache went away, her migraines improved. So detox and then preventive therapy is a good way to go. And I would say primary physicians tend to underutilize preventive medications and frequently just add on more and more abortive medications. And then you just tend to get into this rebound problem. And we really try to avoid narcotics in someone with migraine headaches. Pregnancy might be the only time we'd use like a Tylenol with codeine, just because really nothing is safe during pregnancy. Of all of these preventive medications, propranolol would probably be the safest during pregnancy, but we'd even like to avoid that if we can. Okay, Botox, I should mention also, Botox has become fairly popular for both chronic daily headaches and migraine headaches. When you do Botox injections, which is kind of done in a band around the forehead, temporalis, and cervical paraspinal muscles, it lasts for about 3 months. And so patients come in 4 times a year for Botox injections. And some patients respond quite well. Okay, let's go on to case number 2 here. This is a 41-year-old man, has new onset right frontal headaches for the last 5 months, exclusively on the right side. He has a dull pain that is present most of the time. But he also has episodes of intense throbbing sensation on the right. Feels that his memory is not as good. His neurologic examination is reported to be normal. The consult just came in, so this was what the primary physician reported. And maybe I could just ask you, are you more concerned or less concerned in this patient compared to the last one? Okay, good. What concerns you more about this patient? Yeah, it's just remaining on one side. What else? Yeah, 41-year-old men don't often just come down with new onset headaches. That's kind of an unusual age. And then I heard one of you say his memory is not as good. So there are a number of things here that would raise some concerns, and we'd want to image this patient, right? All right, and again, some of the red flag symptoms here. This patient should have been imaged. Hey, it wasn't imaged. But let's ask this question. Let's say here's the story. We're concerned after listening to the story. You have just a handful of things that you can check on the neurologic examination. What would have be the highest yield? Like you wouldn't want to leave this off. Okay. Which cranial nerves? Sticking out the tongue. What would be the most important, highest yield? Okay. Eye movements or looking in the eye? Yeah, fundoscopic examination would be critically important because what can you tell by looking in the eye? Yeah, papilledema. And something else, it takes a lot of practice, but it is really, you really should just look in every eye if you can, because if you can look at the veins on the retina, and you get used to looking at this, you can see the veins pulsate a little bit. That's called venous pulsations. And venous pulsations tell you that the patient has normal intracranial pressure. And so you'll need to look at this in 50, 100 normal patients, but then it really pays off when you've got that patient in the emergency room with headaches. And you want to know, is this something serious or not? What's going on? And you look in the eye, you see the venous pulsations. It's very reassuring. All right, so the fundoscopic examination, and so I listed some other things here that would be sensitive things we can check for on examination. If you're going to just check some muscles, don't just check the deltoids or the biceps and say, well, it looks like there's normal strength. The much more sensitive muscles to check would be, for example, the distal finger extensors. Those are much more likely, you're more likely to detect weakness, especially if you're comparing side to side, than checking a large proximal muscle. Finger tapping is something I do on every routine screening examination. Compare symmetrical side-to-side finger tapping. Okay, if one side is much slower than the other, you'd be concerned about something going on in the opposite hemisphere. And a little typo here, but reflex asymmetry would be, again, a sensitive indicator of something going on. So it would be some things you wouldn't want to leave out in a screening neurologic examination. Well, anyway, this is what happened with this patient. He was treated with Excedrin, really didn't help. It was given Vicodin, kind of going down the same road here as the first patient, getting worse, and then had a generalized tonic-clonic seizure. So if there's any doubt something serious is going on with this patient, it's confirmed. And he came in, very sad case, with left-sided weakness and coma after the seizure. And here's the head CT. Okay, what do you see on the head CT? Okay, describe where's the lesion here in this case? Right or left? Okay, and what would you say, what lobe of the brain? Yeah, we're here at the pons, the upper pons area. Remember, the most medial part of the temporal lobe is uncus. We've got something large here. Now, this is without contrast, but even then it's pretty obvious. If we do an MRI scan, this is really one lesion. It's just that because it's curved, it looks like it's in two different places here. But now, look at this scan here. We see this involving the medial portion of the temporal lobe. Here's the midbrain. What would be something you might see on examination in this patient, just based on where the tumor is? Are there any cranial nerves that travel right through here? Yeah, the third nerve. This is the midbrain, and this space here is called the interpeduncular fossa. The third nerve comes out here, and so if we have uncal herniation, then that can compress on the third nerve. Okay, this patient didn't have a third nerve palsy, but it would be something we might see. But this was a glioblastoma, high-grade malignant brain tumor. Of course, the prognosis for these is terrible, but we'd sure like to have picked up on this 5 months earlier, right? Rather than now, we really can't do anything, and this patient died a few days later. Okay, so just, red flag things, a younger man, constant headaches, the description didn't fit anything typical, didn't fit migraine, tension type, should have been imaged very early. Okay, third case. A 44-year-old man complains of episodic sharp pain. These were his words, like an ice pick in the right parietal area. Okay, they were initially infrequent, but now are occurring 10 to 15 times a day. Each episode lasts about 2 to 4 seconds and is very intense. He had one in the office while I was talking with him, and he was just normally, talking to me, and all of a sudden he just said, "Oh, hold on," and that was about it. It was over. I mean, he perspired during those 3 or 4 seconds. I mean, this is really intense. Okay, have you ever heard of anything like this? Okay. Cluster headache, how long do cluster headaches last? Generally 30 to 60 minutes. But that's the one thing, if you're trying to remember this later, it lasts on the order of seconds, very intense. Okay, well, you're thinking that trigeminal neuralgia is the other pain syndrome that lasts for a few seconds, but that's in the face, right? Usually in the cheek area. So this is the other condition here that occurs usually in the parietal area, actually sometimes known as ice pick headaches. Okay, but if you remember this, you'll be a hero when you hear the description, because this is such a treatable headache syndrome. And the key thing is it lasts for seconds, very intense, and this can occur hundreds of times per day. I mean, imagine just out of the blue, you get a 10 over 10 headache that lasts for a few seconds. Well, without telling you what this is yet, what's your instinct here? Do you think this patient needs to be imaged? No? Yeah, you're right, but why do you think the patient doesn't need to be imaged? Okay. Yeah, I mean, a sudden onset severe headache would sound like an aneurysm, right? But that's only going to happen one time, right? You're going to have an aneurysm rupture 10 or 15 times every day. So yeah, it sounds like a benign headache syndrome. And the diagnosis here, it's either called idiopathic stabbing headaches, but the preferred term now in my latest neurology textbook calls them indomethacin responsive headaches. We name the headache syndrome by the medication that works, indomethacin. Okay, and there are a whole variety of indomethacin responsive headache syndromes, but the typical feature of it is seconds, very intense, okay, and occurs many times per day. One of the other indomethacin responsive headache syndromes you should know about is a post-orgasmic headache. So if you have a patient tell you after orgasm they get an exploding headache that lasts for a few seconds, that is an indomethacin responsive headache, most likely. I mean, if they just have one and you're seeing them in the emergency room, it could be an aneurysm or something else. But more likely, if it's occurring repeatedly, it's an indomethacin responsive headache. I saw a patient here at the VA who just came in with these vague headaches. Never really got to, it was really unusual how he described it, and I was a little frustrated. And then finally he told me, okay, Dr. Cole, I only have it after orgasm. I didn't want to, kind of embarrassed to bring it up. And so, why didn't you tell me? Because I've got a treatment for this. So anyway, keep that in mind. And you put patients on indomethacin 50 milligrams 3 times a day, maybe for a week, maybe for 10 days. It will stop them completely. Okay, and then often you break the cycle. And so you can take them off the indomethacin. They may come back 6 months later. You give them another course. But it's extremely effective. Okay, so those are not so common, but it's just a very fixable, treatable headache syndrome. Okay, case 4. 34-year-old man complains of intermittent severe headaches behind the right eye. These initially began in the spring of 2002. And he had daily severe episodes of pain that would last for 30 to 60 minutes. I guess I kind of gave that one away, didn't I? After 6 weeks, they resolved, but recurred again the following spring. They returned again during the spring of 2004. It says he can almost set his watch at 9:30 p.m. for the onset of these headaches. He says that the right eye gets red. He has tearing out of the right eye during these episodes associated with right nasal stuffiness. And these have been daily now for 6 weeks. So the patient has what? Cluster headache. All right, so everything here, again, is classic for cluster, which is 90% of patients are men, younger men. Pain is behind the eye, and the headache clusters. So for each individual patient, initially it comes on in the spring or the fall or the winter, whatever. For this patient, it was every spring. Cluster headaches last 30 to 60 minutes, typically, and they keep coming back. And it's a unique feature for cluster headaches, not that they come on for every patient at 9:30, but for each individual patient, they tend to come on at a very typical time. And so many patients tell me, it's a weird thing. They come on at 3:30 every day. Can't figure that out. Okay, but that's something else unique. Also, the eye gets red. You may even have a Horner's syndrome during the headache. Patients get tearing and nasal stuffiness. The only thing that maybe I should add that this patient didn't have is patients with cluster headache, unlike a migraine, prefer to pace the floor. What does someone do during a migraine? Dark room, lights off, quiet. Someone with a cluster headache, they're not light sensitive, they're not sound sensitive. They want to just walk around holding their eye. Okay, so very different. And the reason it's important here, do we need the image? No. Diagnosis is cluster headache. The reason we want to make sure our diagnosis is right is you treat cluster entirely different than you treat migraine. All right, so treatment for cluster headache, how do you knock out a cluster headache if you're in the emergency room? Oxygen. Yeah, high flow oxygen. The best study done on this was just a few months ago, and it was highly effective. So high flow oxygen, if you can get this for your patients at home, it works very well. So high flow oxygen, it's expensive though, and most insurances don't cover it unless you have a PO2 of, 55 or something, and so obviously your cluster patients aren't going to have that. Imitrex works well, but since these are short duration headaches, you need to use the injectable form of Imitrex. Okay, and then preventive. Here, I'd like you just to remember these 2 medications for prevention of cluster headache. prednisone and verapamil. So we start the patient, this patient now is in the midst of 6 weeks of cluster headaches. And so we start these medications together. High-dose prednisone, taper off maybe over a week to 10 days. That knocks out the headache right away. The verapamil is something that will take a while to build up, but works very well long-term for preventing cluster headaches. Okay? Verapamil does not work at all well for migraines. Okay? Verapamil works great for cluster headache. And it's interesting, patients with cluster headache can often tolerate just a massive dose of verapamil, 720 milligrams, or not that I'm recommending that dose, but typically we maybe get the patient up to 240 milligrams. Okay, but this is a very effective combination. I have patients that will just call me, Dr. Cole, the cluster headaches are back. And I can immediately call in, get them started on prednisone, verapamil, see them back in a few days, and it works very well. And so after they've been headache-free, maybe for a month, 6 weeks, then you taper them off the verapamil until they go into their next period of cluster. Okay, there are lots of other medications that work for cluster: Topamax, Depakote, lithium. It's probably the only time in neurology we'll use lithium occasionally. But again, prednisone and verapamil you should remember. Okay, case number 5. 38-year-old woman has had chronic diffuse headaches for the last 5 months. She also says that when she bends over, her vision blacks out for a few seconds. You ever heard of that? Bend over and go blind. She weighs 320 pounds, has been trying to lose weight with several over-the-counter medications. Okay, any thoughts come to mind? Okay, good. All of you said pseudotumor. Why? Yeah, it's the right patient profile. Younger, overweight women tend to get pseudotumor. But what do you think about the visual change? What do you think might be causing that? What's that?
It's like a ball and valve effect type of thing where you like increase ICP, pushing.
Yeah, exactly. This is patients that have papilledema. This is not specific for pseudotumor, but if you have papilledema and you bend over, that shifting pressure around the optic nerve head will often cause transient blindness. So if someone tells you they go blind when they bend over, that would be concerning. And you'd sure want to look in the eye and see if they have papilledema. All right, so again, you have one thing to check on examination in this patient. What would it be? Yeah, the exam is generally normal in someone with pseudotumor. Occasionally they can have a bilateral 6th nerve palsy, but not very often. But what that you should see is papilledema. Okay, I don't have a very good picture of it here, but you may see frank hemorrhages or just a blurred disc margin. Okay, but you'd really want to get a good look in the eye, look for papilledema. So let's say you looked in the eye, there is papilledema, you're thinking pseudotumor. Does this patient need to be imaged? Okay. Exactly. Thank you. It's called pseudotumor because it presents much like a tumor, right? So you could, I remember seeing a patient with a neurology resident years ago, just like this, and we were convinced, great case of pseudotumor. Let's get a scan. And she had a tumor. All right, so you have to image. Now, what would be the reason for doing the imaging first before the lumbar puncture? Yeah, you do a lumbar puncture, and if someone has a tumor, you set up this gradient then between the intracranial contents and the lumbar cistern, and you can precipitate herniation. So you want an image. Would it be important, MRI, CT in this case? MRI? Yeah.
Room in the ER, room 4.
Yeah, MRI is always the right answer unless you're dealing with head trauma, unless you're worried about hemorrhage. Otherwise, we always would prefer to have an MRI. Now, in the real world, of course, in an emergency room medicine, we get a lot more CTs. But you would want an MRI in this patient. Our weight limit for MRI here at the VA is 450 pounds. What is it at the medical center? Does anyone know? 350. Yeah, I knew there was a big difference, but this patient should be able to have an MRI scan, or at least an open MRI. Okay, so MRI is much more sensitive. So we'd want an MRI scan, which was normal. Okay, so now we're going to have to do a lumbar puncture. And here are a couple important things to know about doing a lumbar puncture. If someone is lying down, and remember, when you do a lumbar puncture, you have someone with their legs crunched up. Okay, but when you measure opening pressure, you need to have the patient straighten their legs out. Okay, and then you attach the manometer and you measure opening pressure. All right, which should be, depending on the units you're using, 15 to 18 or 150 to 180. Okay, but that's lying with the legs straightened out. Okay, we will often get calls from the emergency room, oh, I've got an elevated opening pressure. Well, what position was the patient? Because if the patient is sitting, a normal opening pressure is 500 or 50. If the legs are crunched up, the pressure is going to go up. So we have to do it with the patient lying, with the legs stretched out. Okay, and in this case, I don't remember exactly what the opening pressure was, but it went all the way to about to the top of the tube. So we got a very significant elevated opening pressure. So in this context, with a normal brain scan, young woman, overweight, elevated opening pressure, she has pseudotumor cerebri. Okay, so what do you know about treatment? Now that we have the diagnosis, what would we do for this patient? Steroids would be an option. If someone were just cascading down quickly with pseudotumor, that might be an option, but not very often we'd use steroids. Okay, now repeat LPs. How would you like to be the doctor here, seeing this lady who's 320 pounds every week for a lumbar puncture in your office? It does help for a brief time, but the complications of doing a lumbar puncture, you know, you got a post-LP headache and so on. So practically, it's not a good option. But the other thing you mentioned was diuretic. Which diuretic would you choose for this patient? Yeah, acetazolamide. So here's the treatment. Basically, weight loss. And I understand it's even controversial whether weight loss helps, but we usually recommend it anyway. But acetazolamide, which again is a carbonic anhydrase inhibitor, and it acts by decreasing production of CSF. Okay, and so you lower intracranial pressure. Lasix, there's even reports of digoxin, which I've never used for pseudotumor, but acetazolamide would be the drug of choice. Now, two other very important things, though, for follow-up of these patients. You need to have a patient with pseudotumor followed by ophthalmology. And the reason is the most serious outcome for these patients is visual loss, blindness. And the most sensitive way to detect something evolving that needs to be treated is to do formal visual field testing by an ophthalmologist. Okay? And if we're concerned about visual loss, if the patient is not doing well with our treatment, then an ophthalmologist can do something called optic nerve fenestration, where basically they put these cuts in the optic nerve sheath, and it prevents the pressure from being transmitted forward to the optic nerve head. So for visual loss, we have the patient seeing an ophthalmologist. We do optic nerve fenestration. Have any of you seen that in your ophthalmology rotation? No? But anyway, that would be important for the visual loss. And if the headache is refractory, it's not responding to acetazolamide and perhaps other medications, then reluctantly we'll send the patient to a neurosurgeon for shunt placement. And the reason I say reluctantly is, you know, there are complications of putting a shunt in. But I've had a number of patients that have done very well with a shunt placement with just very refractory headaches. Okay, let's go through the last few cases here quickly. 79-year-old man complains of right-sided headaches. This is a patient we saw here last month here in the VA. right-sided headaches, which are new over the last 4 months. He also has a mild fever at times, complains of diffuse aches and pains in the arms and legs. What do you think about? A number of things perhaps should come to mind. Okay, temporal arteritis. Anything else? What should at least come to mind if we're having someone with headaches and fever? A meningitis. Are there any types of meningitis that could brew over months? Yeah, fungal would be the classic. Bacterial viral meningitis, someone's in the ER pretty quickly. A fungal meningitis could brew for a long time. Someone gets a cocci or a cryptomeningitis. That may not present acutely, so we should at least think of that. Well, how about the other you mentioned, temporal arteritis? Could that cause a fever? Sure could. What about the diffuse aches and pains in the arms and legs? Is there something associated with temporal arteritis that might cause that? I thought I heard someone say polymyalgia rheumatica. And that's, a part of temporal arteritis, or maybe, which would cause diffuse aches and pains. So yeah, a lot of that would fit with temporal arteritis. Now, let's say we're thinking about temporal arteritis. And you have one question that if the patient says yes, you'd be convinced. Okay, they've got temporal arteritis. What's the one? Jaw claudication. Very good. How many patients, how specific is that? How many patients out of 100 that have temporal arteritis will have jaw claudication? Say again? 20? Okay. 40? 60? Okay, we're getting close. Jaw claudication, I didn't have it here, but it's about 2/3. So 2/3 of patients will have it. But if they have jaw claudication, you could be pretty confident that they have temporal arteritis. This patient complained of jaw claudication. Now, often it's thought that temporal arteritis, they're just going to have the pain right here over the temporal artery, and you're going to touch it, and the patient's going to go through the roof, and then you're going to know that it's temporal arteritis. But it's usually not that easy. It's often just a vague pain on one side. They may not have any focal tenderness over the temporal artery. But so the jaw claudication here would be very important. Okay, so what would you do in terms of testing for this patient? Temporal artery biopsy. Okay, is there anything you might do first? Yeah, sed rate. Now, in a 79-year-old man with a fever, how good is the sed rate going to be? Well, it's going to be elevated. We know that. But what we're looking for in temporal arteritis is a pretty dramatic elevation. In this case, it was 180 something. It was pretty impressive. So we went on and did a temporal artery biopsy, which confirmed the diagnosis. Okay, so how do you treat temporal arteritis? Steroids, yeah, and what are you trying to prevent? What's the big major outcome? Blindness, okay, which is a pretty high risk, very high risk, untreated. So we want to get steroids started soon, and you can have a patient on steroids, well, for let's say a week or so before you do the biopsy. I mean, you want to do the biopsy right away, but you have a little bit of time where you can have the patient on the steroids and still have a positive result here from the biopsy. You don't want to have the patient on steroids for weeks, though, before you do the biopsy. This patient we had just last month here in the hospital, new diagnosis of temporal arteritis, horrible headaches, and put him on steroids. The next day his headaches were gone. Jaw claudication was gone. So patients respond very well, typically. Okay, let's do this one quickly now. 35-year-old woman complains of severe right facial pain, primarily in the cheek area, brought on by eating, brushing her teeth, even talking. At times, it seems the entire right side of her head hurts. Episodes of pain last for several seconds. Okay, we talked about this condition and are incapacitating. So a patient has what? Trigeminal neuralgia. And trigeminal neuralgia is brought on by anything that moves the jaw. Talking, chewing, brushing teeth. And here's something that I have seen in so many patients with this. if you can't move your jaw and it brings on this severe pain, patients often will lose a lot of weight, 30 pounds in this case, over just a few months, because they just are afraid to eat. We even saw a patient who had a thiamine deficiency from this because she just wasn't getting nutrition. And then here's the other thing that I've seen again and again. This patient's seen 3 dentists, 1 ENT doctor with a negative workup. And no one thought about trigeminal neuralgia. He's even had a tooth pulled for this. Didn't help. Okay? So it's trigeminal neuralgia. Now, let's say, would you image this patient? Would you do a scan? Well, you probably should. The yield is low, but it is recommended that patients have an MRI with contrast. And the reason is, occasionally patients will have benign tumors, like schwannomas that may compress the trigeminal nerve. And the other thing you want to think of in a young person with trigeminal neuralgia is multiple sclerosis. Because as the trigeminal nerve fibers enter the pons, peripherally they're myelinated by Schwann cells, but as they enter the pons, they are myelinated by oligodendrocytes. So if you have demyelination in the pons from MS, that can present with trigeminal neuralgia. Okay, so you do an MRI scan. It's usually normal. And how do you treat trigeminal neuralgia? Is there any abortive medication? You can't abort a pain that lasts seconds, right? So we're in the area of prevention. And what would you use? What's a drug of choice for trigeminal neuralgia? What's that? Carbamazepine, yeah, it's a drug of choice. So Tegretol or carbamazepine. Now here's a question that's on your subject exam every single time. Carbamazepine, what are the side effects of carbamazepine? Yeah, that's the one I wish they asked. An aplastic anemia. And so we have to do a CBC every few months, but that's not the one they ask. What's the other side effect of carbamazepine? Yeah, hyponatremia. And what's the mechanism for hyponatremia? Remember, it's a SIADH. So you need to remember that carbamazepine can cause hyponatremia through SIADH. And they always ask that one. They never ask about aplastic anemia for whatever reason. The other one I'd remember that's unique for carbamazepine is double vision. Maybe 8 or 10% of patients on Tegretol get double vision. But anyway, this is the drug of choice for trigeminal neuralgia. The next one, some people go to Neurontin or gabapentin next. Personally, I've just had such good success with baclofen that that's the next one that I use. And I think after that, you probably don't need to worry about the rest of these. Dilantin works. Actually, a good trick if you're going into emergency medicine and you see someone coming in just with episode after episode of trigeminal neuralgia, you want to do something to get them out of the emergency room. You can load them up with maybe 500 milligrams, maybe 700 milligrams IV Dilantin. It'll work quickly. It'll knock out the pain. You can get them out the door until maybe an oral medication kicks in over the next few days. Topamax works, and there are a whole bunch of surgical options, gamma knife therapy that can be done for a real refractory case where all of these oral medications aren't working. Okay, these last two are quick. A 37-year-old woman complains of new onset headaches. They're diffuse, very severe. And here's the unique thing. They completely resolve when she lies down, but return when sitting. You ever had a patient tell you something like that? I lie down, it's gone. Sit up, 10 over 10. And you can imagine, you walk into the exam room and this patient, she's lying down. What if I told you the patient had a procedure a few days ago? Yeah, a lumbar puncture. This sounds like a post-LP headache, right? Problem is this patient didn't have a lumbar puncture. So this is another one, like the idiopathic stabbing headaches, where once you've heard it, hopefully you'll remember it. And again, it's such a treatable thing. You want to recognize the unique presentation of this. And so this patient has something that's known as spontaneous intracranial hypotension. And the mechanism is really much the same as if she'd had a lumbar puncture. It's just that it's a spontaneous leak. Okay, and what happens is if you have a spontaneous leak, then the buoyancy, the CSF, the brain literally just floats in CSF. And if you have a leak, and this could be cervical, thoracic, lumbosacral, the brain just sits down a little bit. And so every time you sit up, because of that effect, and the brain is kind of sinking down, you get a severe headache. You lie down, it goes away. And so it sounds like the patient had a lumbar puncture, but they didn't. Diagnosis is spontaneous intracranial hypotension. And testing, how you can nail this down is to do an MRI with gadolinium. Notice, with gadolinium. Because here's an MRI with GAD. And you're probably not used to looking at these, but notice the meninges here, just lighting up with gadolinium. It's really complex what happens, but when you have spontaneous intracranial hypotension, because of the brain just sinking down a little further, the meninges light up. And when you see that, this is not meningitis, this is spontaneous intracranial hypotension. And the treatment is blood patch, just like you would do for a post-LP headache. You call your anesthesiologist, they draw up venous blood. How many of you going into anesthesia here? Yeah, so you'll get some phone calls for post-LP headaches. And this, I would think, is a pretty rewarding thing to do for an anesthesiologist, because these patients come in with a severe headache, you do a blood patch, and within minutes, it's gone. Fixes the headache. Okay, the blood seals off the leak, and patients walk out fine. Okay, so again, another very rewarding thing. I've maybe only seen 3 or 4 patients with this, but in every single case, within minutes of a blood patch, their headache was gone. Okay, last case. This is the only one I made up. Okay, but this is the one that you'll probably get on your subject exam. 49-year-old woman complains of a sudden onset headache while working out. What does that tell you? Yeah, boards are in a rut. They always ask the same thing. It's always someone working out. This is an aneurysm rupture. And pains on the top of her head and her neck. This is the most severe headache she's ever had. And she comes to the emergency room. So this is a ruptured aneurysm. Okay, but more important than worst headache of my life, because of course someone could have a worst migraine of their life, is the sudden onset. Okay, when an aneurysm ruptures, it's just instantaneous. Migraines build up over a period of time. Sudden onset headache of a new first-time problem would suggest an aneurysm. Okay, so what you may find on examination with subarachnoid hemorrhage is severe neck pain with flexion, because remember, the subarachnoid blood irritates the meninges, so when you push your chin to your chest, you stretch the meninges. That tends to worsen the headache. I need to include a picture of this, but you may find what's known as a subhyaloid retinal hemorrhage. Again, looking in the eye, you may find a focal hemorrhage there. But generally, the examination is non-focal because the blood goes into the subarachnoid space. Now, anyone remember the one focal finding we talked about first-year neuroscience course that you can see with a subarachnoid hemorrhage? Big pupil, third nerve palsy. Okay, because remember the posterior communicating artery runs right along with the third nerve. So if you have a posterior communicating artery aneurysm, you'll get a third nerve palsy. Sudden onset headache, third nerve palsy. But otherwise, it's non-focal. Now, diagnosis, how do you diagnose subarachnoid hemorrhage? Yeah, hemorrhage. We want a CT. So maybe a question, how good is a CT? You're working in the emergency room, you do a CT, 20%, 40%, 90%. Yeah, it's 90% sensitive in the first 24 hours. It goes down to about 50% by week 1. But if you're doing a CT and the patient's within the first 24 hours, it's going to be positive, generally. So you don't have to go on and do a lumbar puncture. But if you get a normal CT, you need to do a lumbar puncture. And since this is important, just very briefly here is what just drives us crazy. We do a lumbar puncture and we put all the fluid in one tube and send it off to the lab. And we get this: 500 red blood cells, 6 white blood cells. And what could this be besides subarachnoid hemorrhage? Traumatic tap, right? So never do that. You want to check in tube 1 and in tube 4, you get the same number of red blood cells in both tubes. It's subarachnoid hemorrhage. What's the other thing you should be ordering to distinguish between subarachnoid hemorrhage and traumatic tap? Xanthochromia. Xanthochromia, again, will be positive if it's a subarachnoid hemorrhage. So I order this in every lumbar puncture besides putting the fluid in different tubes. And then once you've diagnosed that, you'll do an angiogram of some sort, and you'll get the neuro or vascular surgeon involved to evaluate the aneurysm.